I request all the panelists to kindly keep their videos on. Thank you. Thank you very much. Hello, Sarabjit ji. Sumit ji, welcome. We have right now who has attended, that's Ashir Rauf, welcome. Ayat Jan, welcome. There is Banish Kharmanglaw, Bobby Kunti, Divyansh Tiwari, Dr. Prince, Dr. Sharberry, Sarude, Ivanela Patho, Harilal Pandit, Haneet Kaur, Jayant Jain, Kamlesh Suresh, K.M. Sonam, Landilin Shandir. I'm sorry if I cannot properly pronounce your names. I will be very, very sorry for that. Because most of the times we have the people joining us from the neighboring countries as well. So the names are a much bit different from the Indian ones. We have with us Lendig Shandigir, Manoj Kumar Singhal, Miss Anshumala Nandani Wade, Nilofer Ibran Ali, Nidhi Goswami, Nimish Sharma, Niranjan K, Parthiv Mandal, Pradeep, and the participant list is big. So I hope we will now be starting. I think we should start now, sir. We have good number of people who have already attended us.
It is 5:10. Shall we start, madam?
Yes, yes. Okay, I hope everybody is present over here. Okay, let me start. Namaskar and welcome to the webinar on tuberculosis of spine. Again, a Saturday, 2nd December 2023, we are back with yet another mind-blowing session with our eminent authors, Dr. Edward Nazareth and Dr. Jacob Appy, authors of Textbook of Orthopedics, published by CBS Publishers and Distributors. This session will be made more thoughtful by the presence of our amazing panelists who will make your understanding on this topic more enriching and joyful. I would like to welcome on this show Dr. Nirath Hegde and Dr. Sandeep T.
Thank you, ma'am.
Before we start with today's scientific session, I would request Dr. Ashu Singh to kindly present a welcome note for today's session. It's over to Dr. Ashu Singh.
Thank you, ma'am. Good evening, everyone. Before we delve into our insightful discussion today, let me take a moment to introduce our esteemed panelists, that is Dr. Edward Nazareth, Dr. Jacob K. Ipe, Dr. Neerath S. Hegde, and Dr. Sandeep T. Dr. Edward Nazareth is an ex-professor and head Department of Orthopedics at Father Miller Medical College and is currently Professor Department of Orthopedics, Srinivas Institute of Medical Sciences and Research, Bangalore. With over 30 years of undergraduate and postgraduate teaching experience in orthopedics, Dr. Nazareth is also a well-known academician and clinician in orthopedics. He has been a faculty member for several PG teaching programs in South India and an examiner for several universities. He is the main author of the book Textbook of Orthopedics for Undergraduate as per the CBME curriculum. Now, our second panelist, Dr. Jacob K. Ipe, is currently Assistant Professor, Department of Orthopedics, Saptagiri Institute of Medical Sciences and Research Center, Bangalore. He is also the author of Orthopedic Navigator and Orthopedic Guide for Postgraduates, as well as co-author of a textbook on orthopedics, alongside multiple national and international publications in reputed journal. Dr. Jacob holds a key interest in academics and teaching and is always found mentoring and guiding young budding orthopods in his spare time. He is also a core committee member of the SMOT Orthopedics Trauma Center and an ex-faculty of Medicis Edu involved in teaching young students. Now we come to our third panelist, Dr. Neerath S. Hegde. He is an orthopedic surgeon from Mangalore, presently working at Kanchur Medical College. He completed his studies at Hassan Medical College and his residency at Srinivas Medical College. He enjoys teaching and has few publications to his name. Now, our fourth panelist, Dr. Sandeep T., is an infectious disease specialist and associate professor of microbiology at Ramya Medical College. He has done his MD in clinical microbiology and master's in infectious disease from Nicaragua University and currently pursuing fellowship in ID from University of Manitoba, Canada. He is an affiliated member of IDSA and ECCMID with 14 publications to his credit in reputed journals. With 14 years of teaching experience for MBBS students, he has also played a crucial role as an examiner for both MBBS and MD programs across all states in southern India. Now I'll be handing over to ma'am.
Thank you, Dr. Ashu, for presenting the welcome note. I would now request, before we start with the topic, on the spine, tuberculosis of the spine, I would request my co-host, Ms. Simran, to kindly present the code of conduct for the day. Ms. Simran.
Hello, everyone. I wholeheartedly welcome all the esteemed panelists and our students for today's valuable session. I will be reading the code of conduct for today's session now. All the participants may kindly keep their speakers and mics mute during the session. If anyone has any query during the session, kindly raise your hands or message in the chat box. The moderator will address it during the end of the session. For the Q&A session, all the participants can put their questions in chat box, which the moderator will take up at the end of the session. Special attractions for the attendees for today's session. 3 winners will get free books based on various parameters of the participants. Free access to ebooks at EduPort for 7 days. 30% discount on textbook of orthopedics by Dr. Nazareth and Dr. Jacob till Monday morning. And e-certificates for all the attendees. I hope you all have a valuable session today. Thank you. Over to Ms. Anu now.
Thank you, Simran. Thank you very much. Now, I welcome you all of again, our amazing panelists. I would request now Dr. Sandeep T. to start with the session. The topic Dr. Sandeep shall be handling is ethopathogenesis and pathology of tuberculosis of spine. It's over to Dr. Sandeep T. Dr. Sandeep.
Thank you, ma'am, for that kind introduction. And at the outset, I would like to thank Dr. Edward sir, Dr. Jacob, and CBS publishers for inviting me to be a part of this talk. I'll just take a minute to open the PPT and share the screen. Then we can start. Is my slide visible to everyone?
Yes, sir. Yes.
Okay. Okay. So the topic for today is TB spine. A really interesting and challenging topic as a clinician, orthopedician during your OPD. So what we'll do is, just before we go into the hardcore, say, microbiology part of it and the pathogenesis, let's go to Dr. Jacob's clinic, where a patient has come to him with just that, MRI on the right side that you can see. He has just come with that MRI and he's asked for Jacob's opinion. So Dr. Jacob is suspecting TB spine, and he has revealed to the patient that he might be having this condition. So the first question what the patient asks the doctor is, how did I get this disease? Where did this TB come from? How did it reach spine? Why couldn't my body take care of it or kill it? Okay, so these questions are generally encountered, during our practice estimations. So to address this, okay, we are going to help Dr. Jacob to answer these questions to the patient. So let's get our basics first, strong. Everyone knows, yeah, all of us know that TB stands for tubercle bacilli. The technical name of that is Mycobacterium tuberculosis. But this is what we have been taught as second year MBBS students, and that is okay, that is correct. But then when we are actually practicing, and with the variety of or the diversity of students and doctors across the world, I think we should not just stop it at Mycobacterium tuberculosis. We should add another word called complex there, because there are 4 organisms which belong to this group of Mycobacterium tuberculosis complex, which can cause human infections. Some of them, or one of them, is common in India, one of them is common in Africa, and other Asian countries also. So it's better to call it as a Mycobacterium tuberculosis complex rather than just one bacterium, that is Mycobacterium tuberculosis. Anyway, what do we know about this bacteria? This bacteria is an acid fast bacteria. That is what we have learned in our second year MBBS. It looks pink when you stain with that Zn stain, like the picture that has been shown on the right side of the slide. Okay, in a blue background. Okay, that is a traditional way that traditionally we have been taught, and we all know about that. Now, where did this bacteria come from, or where is it generally present? It's present only in humans. Okay, source of infection is humans. And what type of humans? They are infected individuals. When I say infected individuals, the bacteria is present in their lungs. And these patients, not all patients who have bacteria in their lung become a source of infection. We have to qualify that with another condition, that those patients who have the bacteria in their lungs and they are able to cough it out. Okay, so if the bacilli or the bacteria is detected in their sputum, only those patients can be considered as source of infection. Only they are able to transmit that infection from one individual to another. If the bacteria is silently present in the lungs where you cannot detect that in the sputum, then that person cannot be considered as source of infection. This holds good, or this concept is good only for pulmonary tuberculosis. Now here the topic is not pulmonary tuberculosis, it is extrapulmonary tuberculosis, that is spine. So when we talk about, or when you get a question, or let's say, how do you answer source of infection for extrapulmonary TB or spine TB? It is always endogenous source. Okay, it is never got from another patient. That is, spine TB is not got from another patient. It is always the bacteria is present in the patient himself or herself, which is there in the lungs, and then it goes to the spine. Okay, so in spine tuberculosis, the source of infection becomes humans, endogenous source, and generally it is in the lungs. Sometimes or occasionally, genitourinary TB can predispose to spinal tuberculosis. So that is where the bacteria comes from. Now, how does it get transmitted from patient to patient? Suppose we are talking about pulmonary tuberculosis, that's where the bacteria is spreading from one person to another person. So there it is, the mode of transmission is inhalation, it is droplet infection. Okay, inhalation by breathing in, those droplets which have these bacteria in it, that's how we get that infection. Droplet infection means the the probability of getting an infection from an infected person is very high when you're close to the patient or close to the person. Okay, within 3 feet of that patient. If you're standing or if you're away more than 3 feet of the infected individual, then the chances of getting that infection is low. Okay, so that is what is meant by droplet infection. If we, the other aspect of that is airborne infection. Okay, airborne infection is also a part of inhalation mode of transmission. So airborne infections, whether you stand close to the patient or away from the patient, you are bound to get that infection. That is airborne infection. So that is classically described in influenza virus. But luckily for us, tubercle bacilli does not spread far away from the patient. So it's going to stay very close to the patient. Whoever is coughing, sneezing, okay, within the 3 feet, if you're there, then the chances are high that you're going to get that bacteria into the lungs. Now, what happens in the lungs? This bacteria is going to form a primary complex in the lungs. So it's going to infect, damage a little bit of the lungs, and it's going to remain there. Okay, it's going to be a dormant bacteria. It just waits for a chance to flare up, starts multiplying, and causes a lot of tissue damage. So when we look at TB in adults, be it pulmonary TB or extrapulmonary TB, we always label it as reactivation tuberculosis because the bacteria which is already present in the lungs, when given a good chance, starts multiplying and causes tissue damage of the lungs or in the spine. So reactivation tuberculosis is what we have to look for, and label the patient or label the condition as reactivation tuberculosis. And mind you that this, just because the patient is having TB in the spine or any other extrapulmonary site, it doesn't mean that the patient can transmit that infection to another person. Okay, you need not isolate or give airborne precautions for such kind of patients. We follow airborne precautions only for patients who are an open case of tuberculosis where the bacteria is present in the sputum, who are able to cough out the bacilli. Only for those patients we follow that airborne precautions, wearing masks and all that. But for extrapulmonary tuberculosis, they are not considered to be transmitters of the infection. So we need not follow precautions to a very great extent. Obviously, for all patients who are infected, we do follow precautions, but it is not mandatory. I can put it like that. Fine. So this is a diagram which shows what exactly happens in the natural history of EPPD. So what happens is the person gets the bacteria through the droplet, goes into the lungs. Okay, primary infection, primary complex is formed there. Okay, this is the granuloma. I'll be showing it to you in the next slide, a bigger picture of that. Then there is latent infection. The bacteria is very silent, doesn't do anything. So people don't know that they have the bacteria in them most of the times. But when given a chance, it can spread through the blood to all parts of the body, all organs of the body, and then can cause extrapulmonary tuberculosis in various organs. Okay. Yes. Now coming to the question, why spine? Okay. There are some reasons why people get TB in the spine. One of the theories that have been proposed is that it has a very rich blood supply. Okay, there are a lot of the spinal arteries, anterior, posterior, all that, those arteries which supply the spinal column. Okay, now if you look at this theory, that is rich blood supply, of course, if you compare the other organs or vital organs like brain, heart, and all that, all of those organs are also have a rich blood supply. But what we have to remember is that this bacteria, the tubercle bacilli, likes oxygen very much. Okay, so wherever there is rich blood supply, there are high chances that this bacteria is going to multiply over there. Okay, the primary reason why apical lungs are involved, because the oxygen content or oxygen concentration is very high in those regions. So rich blood supply gives a good oxygen supply to the bacteria and actually helping it to multiply and cause the disease. The next theory or the reason is that intervertebral discs, these are not directly supplied by the blood vessels. Okay, so it means to say that the antigens present in the disc are not exposed to the immune system. Okay, so this part of the body, that is intervertebral disc, is called immune sequester. Means to say whatever happens in the disc, the immune system does not have a direct access to it, and uh, and the bacteria gets an advantage, okay, to be in that place, starts multiplying and destroying before the body can actually detect it and mount an immune response. So that is why the disc the space or the area around the disc is the one which has this bacteria in it and starts, the bacteria, rather, I'll put it like this, the bacteria starts its process of destroying from the place around the disc and then it goes into it. Okay, so yeah, the next reason or the newest concept now is that there are some mutations in vitamin D receptors which predispose an individual to spine TB. Okay, it is not like all of the patients who have pulmonary TB should have spinal TB at later stage. It doesn't happen like that. It's never like that. So only few people end up having this spinal TB. So if you look at it, some of them have been studied with respect to this vitamin D receptors, and they found that certain mutations, are common in those patients who have spinal TB. So there is a theory that mutations in vitamin D receptors can predispose to spinal TB. One more interesting thing here is, what happens? So here, the bacteria, whether it is there in the lungs or it is there in any other extrapulmonary site, the process or the pathology is the same. It's going to have a granuloma formation. Granuloma formation, all of us know that it's an inflammatory process. It's an immune response mounted by the individual immune system against the bacteria. So here the diagram on the right side of the slide, you can see this is how a granuloma looks like. The central part has it has necrosis. It has the bacteria in it. Okay, it's surrounded by these cells, light brown colored cells here. They're all macrophages, modified macrophages. Can you appreciate that each macrophage is interlinked? It's something like holding hands. Okay, this is what happens. The macrophages are not able to kill the bacteria. Okay, so what we call as frustrated phagocytosis. Okay, so this happens typically in tuberculosis. So these macrophages, their primary function is to eat up the bacteria and kill them. That does not happen here with tubercle bacilli because tubercle bacilli is more stronger. It has a lot of other strategies to escape that killing by macrophages. So what happens? What does this macrophage do? It starts forming a boundary like a fourth wall, okay, around the bacteria so that the bacteria does not escape out and cause further damage to the tissue. Okay, so after this barrier, the lymphocytes are there again to support these macrophages and help in containment of this infection. But for all this, you need a good blood supply, and the immune system should be able to reach that place where the bacteria is present. So what happens in the discs? That is not possible. Okay, the blood supply though is good, only the bacteria has the advantage because the interior, the central part of the disc is kind of very protected. It is not supplied by the blood. There is no blood vessels at all. So the immune system cannot reach that particular place. So that's how the entire disc is destroyed by this bacteria. So when you look at it, it can cause, it starts with paradiscitis, that is the area around the disc has this inflammation. And then the disk is destroyed. But a peculiar thing is that this disk destruction or disk involvement is generally common in young age because these blood vessels are good. Okay, there is good blood supply and the bacteria can easily enter or reach the disk. But what happens in the old age, the discs are generally not involved. I wouldn't say not, totally not involved, but they are generally not involved because the blood vessels are shrunken, they are atherosclerotic, and there is no less chance of the bacteria going to that particular area. So in old age, what happens? The vertebral body gets involved more common as compared to the discs. So the moment the vertebral body gets involved, okay, what happens? There is inflammation there, and the bone gets lysed. So osteolysis is present, and where does it start? It starts in the anterior inferior region and then spreads. Okay, one more thing that you have to remember is that adjacent vertebral body is involved due to the common blood supply. So you have to go back to your anatomy classes to see that a single artery is going to supply half of the vertebral body above it and half of the vertebral body below it. So the adjacent vertebral body gets involved because one artery is going to supply that bacteria to these areas. Okay. The other things that is possible in spinal TB is that there can be a thrombosis in that particular spinal artery, and there has been this concept of non-contiguous vertebral involvement has been documented. It is seen in clinical cases. What is this non-contiguous vertebrae? Means to say the this proves that this bacteria has come from a single source, that is lungs, and not anywhere else. Okay, what do you mean by non-contiguous? The vertebrae are all numbered, like you already know, T, L with followed by a number. So when we say non-contiguous, the numbers follow the continuous numbers. Say second, third, fourth vertebrae together will not be involved like that. Okay, second will be involved, third will be spared, fourth will be involved. So that is non-contiguous involvement of vertebrae. Fine. So suppose left alone, there can be arachnoiditis, myelitis, fibrosis, all that are further seen in the natural history of TB spread. So with this, what I would end the pathogen of my section, that is the etiopathogenesis of spine TB. I would request the other doctor to continue with clinical features in the management. Thank you for your patient hearing.
Yes, thank you, Dr. Sandeep. This is Dr. Neeraj from Mangalore. If a student has asked before going into my topic, what should be the safe distance one should keep while taking history from a confirmed case of TB?
Yeah, very, very interesting question. Good question. See, I would say rather than keeping a distance and concentrating on the measurement of distance, should I stay 3 feet, 4 feet, all that? It's a little taxing on us. So what I would suggest is better to wear a mask, N95 mask, stand next to the patient and take the history. That would be the easiest thing to do. If at all you don't have a mask, then more than 3 to 4 feet distance is what is recommended.
Thank you, doctor. Yeah, that's what. Give yourself a mask and give the patient also a mask and stand next to it is what sir is telling. Okay, I'll share my content now.
Are you not able to do what happened, Nirath?
Yeah, sir. The option of sharing the screen is not there. I'll try to send it from the drive.
Is there down?
I would suggest
No,
the
sir. Screen
audience
option
to
is not there. I'll try to share from the drive, sir.
put the questions across to Dr. Sandeep T based on their topic. I would request anybody from the audience, if they have any questions, they can put across in the question answer box. We will ask this subject expert to kindly answer the same. Yes, anybody from the audience, they can raise their hands or put their questions in the question answer session. Yes, there is a question. Dr. Sandeep, are you able to read the question from the question answer type?
Yes, ma'am.
Yeah, there's a question.
Ibrahim Mullah has asked a question on management of kyphosis and gibbous formation due to TB spine.
That we'll talk later in the
Yeah,
management. That is the management section.
Yeah.
Yeah, Nirath is sharing his seats. We'll start.
I would like. Yes, I would request all the participants to put their questions in the chat box. All their questions will be taken after the scientific presentations are over. So they can start putting their questions in the chat box or the question answer chat box. Yes, it's over to Dr. Neerath Hegde.
Yeah.
Nirath, do you want me to share from here? What happened?
Yes, sir. The option of sharing screen is not coming, sir. That's why I'm trying to
Sir,
share
we are
from
able to see your presentation, Dr. Hegde.
Yes, share now. We are able to see.
We are able to see your presentation.
That slide.
Okay, this is enough. I think
Slideshow
we'll
is
manage.
there. Now they click that.
Yeah, it is not letting me do the slideshow, sir. Just a second.
Or you want me to, madam, you want to share from there, your side?
Yeah, if that is possible, that's best, sir.
Yes, Dr. Hegde.
Is your
Yeah.
Do you want me to
These
share?
slides are there with you, madam?
Yes, yes.
Yeah, please do that. The option of sharing the screen is not there, sir. From Drive, it is not going into slideshow. So if you can share the slideshow from your
You are
end,
not
I
using
would.
laptop, is it? You are
Sir,
not
you
using
have to stop sharing, then I can do it.
Yeah, I have stopped sharing.
who
Ma'am, are you sharing it from your end? Yeah. Okay. Yeah, we can start the slideshow. The option of sharing screen is not there, so we'll play the slides from there and we'll discuss it from here. Yeah.
Sir, I have
Sorry for the
shared.
disturbance.
I have shared already.
Yeah, you can start the slideshow.
Okay, sir.
Yeah.
The first slide is this. Another is this, sir.
Yeah.
Yeah, okay, fine.
Can you start the presentation, please?
Yes, sir. It's already started. I have already started it.
Make it full screen, please.
Pardon me?
Full screen.
Can you full screen?
Full screen.
The slideshow button on the right side. Yeah. Left. Yeah. Yeah, the red button, ma'am, on the right down. Yeah. Yeah.
Is it okay, sir?
Yeah. Can we go 2 slides back?
Yes, sir.
Yeah. Sorry for the delay. I would like to thank CBS publishers, Dr. Jacob and Edward sir for this opportunity to have a class on pathology and clinical features of the spinal tuberculosis. I am Dr. Niraj from Mangalore. Firstly, we will discuss the pathology of the spinal tuberculosis. The next slide, please. Yeah. The manifestation of the skeletal complications of TB or skeletal manifestations of TB are seen in a less number of patients when compared to the pulmonary or the gastric components of it. That is seen in about 1 to 3%. And the most common site of the skeletal bone that is involved is the spine, followed by the knee and the hip. Next slide, please. In the spinal tuberculosis, it is usually a combination of osteomyelitis and the arthritis that is there. where the subchondral plate is involved, mostly because of its good blood supply which is there in the spine. In adult, the vertebral body is more involved when compared to the disc, but in children, the disc tends to get more involved because of its high vascular supply in young individuals. This progresses to form the collapse of the body because of the osteomyelitis, and later a progressive forward bending of the individual is seen, which is called as kyphosis. This collapses can spread along your facial planes, along anteriorly, posteriorly, or paraspinally to reach various parts. And this forms a granulomatous tissue with no signs of inflammation, what we call as a cold abscess. And the compression on the spinal cord and its structures can lead to paralysis or neurological complications. Next slide, please. So this is a diagram where the source of the extraspinal spores, that is from your intestine, from your genitourinary, or from the lung, which is the most common site from where it reaches the spine. The blood supply of the upper part of the lower vertebra and the lower part of the upper vertebra is same. So hence the tuberculosis tends to get involved in a similar fashion, involving the lower half of the upper vertebra and upper half of the lower vertebra. And sometimes the disc can also be involved, and it's from the paradiscal area. It can destroy your disc, leading to the arthritis of the spinal column. Next. So anatomically, based on the involvement of the tubercle bacilli or the destruction of the spine, it can be paradiscal, that is adjacent to your disc, and it can be posterior, where your posterior elements, that is the lamina and the spinal process are involved. It can be central, that is your body that is getting involved due to the venous spread from the posterior, or it can be the anterior part, which is your longitudinal ligament and the anterior part of the body that is getting involved. And rarely your facet joints, that is synovial joints, also can be involved in tuberculosis. Next, please. Yeah. This is the diagram showing the spread or the involvement of different parts of the spinal column. The most common region where it can be involved is your paradiscal region, where the adjacent to the disc, as I told you, has a very good blood supply, leads to the destruction of the paradiscal area, and it is always involving the lower half of the upper vertebrae and the upper half of the lower vertebrae. This leads to the atrophy or in the destruction of the disc and the narrowing of your disc space, which can prolapse into your spinal cord and cause compression symptoms later on. Next slide, please. Yeah. The other type is the central type, where the body is getting involved, and it leads to the loss of the height of the vertebral column that is there, and it can lead to a concentric collapse. That is, the height goes on decreasing of the vertebral body. Another type is the anterior type, where the anterior column and the longitudinal ligament is getting involved. This leads to the erosion of the anterior body surface, leading to wedging of your vertebrae and the progressive kyphosis that is there. Next, please. And another rare condition where the posterior elements can get involved, that involves your posterior spinous process, the transverse process, and the lamina. And the disc space is usually not involved in this scenario, and the disc space is intact. Next slide. This destruction can lead to the formation of the cold abscess. What is a cold abscess? Why it's called cold is because it does not have your classical symptoms of the virtuous triad, that is rubor, calor, and dolor, that is redness, pain, and the rise of temperature that is commonly seen with any inflammation. This is because the granuloma that is formed, or the liquefaction necrosis that is happening in your spinal cord, is surrounded by your granulation tissue or a granuloma which is formed. And this contains your bony debris, the caseous material, the leukocytes, and the TB bacilli itself, which is surrounded by the smooth fibrous tissue that is there. However, as I told you, it does not have your signs of inflammation. Hence, its name, the cold abscess. Rarely, it can burst open to form a sinus or a non-healing ulcer. These are the various sites which you on the right side which you have where your cold abscess can normally be seen. And this is the diagram of a cold abscess that is involving your lumbar area. Next slide, please. What happens is, as the TB bacilli is there, it gets phagocytes, the monocytes and the macrophages reach there, leading to a Gardner formation. It contains your epithelioid cells, the macrophages, the fibroblastic cells, and the tubercular bacilli, which are surrounded, and it forms an abscess. This caseous material forms a composed structure or a yellow mass, and it can break down to the external environment or as form an abscess and drain along your facial parts. I'll be dealing where and all it can present later during the end of the discussion. Next slide, please. We have some images of the cold abscess that is there. This is the cold abscess draining in the cervical region from your cervical triangle. This is the cold abscess where it is on the left you have the lumbar cold abscess, and on the right you have the cervical region cold abscess which has reached your supraclavicular area, and this is your thoracic cold abscess and which can present sometimes anteriorly also. Next slide, please. Coming to the clinical features of tuberculosis, what the constitutional symptoms that what you know are anemia, loss of appetite, loss of weight, or the chronic cough is there, that can be usually absent in a spinal manifestation, which are ideally seen in your pulmonary tuberculosis. The spinal TB that can present to you with neurological symptoms or without neurological symptoms. That is, the cord getting involved can lead to paralysis, or sometimes the cord is not involved and the patient might have a spinal TB without any neurological deficits. Other sites where the TB can manifest is your lymph node, where there is a swelling of the lymph node, where other bony TB which is there, that is leading to pain and swelling of the joints, and the spinal TB where there is stiffness, pain, and paraplegia later on if the spinal cord is involved, brain, the GIT, and the pericardial area. Next slide, please. Coming to the symptoms. Symptoms are what patients manifest to you with. The patient usually has a back pain, which is diffuse in nature in initial stages. Later gets localized to the segment where the TB is involved. As a result of the TB destroying the spinal vertebral column, you have the body protective mechanism where the paraspinal muscles, which are present on the either side of your spine, that prevent this movement as the patient usually has pain and they go into spasm. Hence, the whole back is stiff. However, when the patient sleeps in the night, these muscles relax, permitting movement between the inflamed areas of the spine, leading to night cries or increased pain when the patient sleeps. These are called as night cries. These are some of the common symptoms that you are seeing in a TB spine. Next slide. Coming to the clinical signs, that is what we see when a patient walks into our OPD. There can be a deformity, that is the kyphosis that is there. What is kyphosis? Kyphosis is nothing but because of the destruction of your vertebral body and the bony structure that is there, or the spinal column, the patient has a progressive forward bending. That is known as kyphosis. Since we are discussing more about the thoracic region, which is more common in your TB of the spine, there is a progressive kyphosis that is there. However, other deformities can also be present. Then in 20% of the cases, because of the involvement of the neural component, they can have paraplegia or paraparesis. That is the loss of motor control or the motor function is lost because of the compression of spinal cord. Then they can have cold abscess. Cold abscess are swelling because of collection of the abscess of your TB bacilli. Next slide. Coming to the deformity, as I told you, this is the thoracic region where there is a progressive forward bending and you have a kyphotic spine. And If a single vertebrae is involved, what you call as there is prominence of a single spinous process, what you call as a knuckle kyphosis. If two or three vertebrae are involved, you lead to the prominence of two spinous process, that is your gibbous formation. More than three vertebrae when they are involved, it leads to an angular deformity in your thoracic region known as your angular kyphosis. Next slide, please. Coming to the Pott's paraplegia, Pott was the first person who described about the spinal manifestation of tuberculosis, where the spinal cord compression is leading to paraplegia in individuals with TB spine. It is more common in the first 3 decades of life, and the most common region that is involved in the thoracic spine is the lower thoracic vertebra, the L11 and L12. And in these cases, about 10 to 40% of them have neurological deficits. The paraplegia can be of an early onset type or a late onset type. In early onset type, why the patient is having paraplegia is because this disease is active and the active disease is itself affecting the spinal cord. In late onset, because of the complication or the destruction of the vertebral body and the spinal column that has already happened, it is leading to pressure problems over the spinal cord, leading to paraplegia in a heel disease. Next slide, please. Okay. We have the neurological involvement or the Pott's paraplegia, which is there. It can be because of two main causes, the extrinsic and the intrinsic causes. Extrinsic causes is something that is there on the outside compressing on your spinal cord. Intrinsic causes are those where the spinal cord is itself involved or the dura and the surrounding layers are compressing on the spinal cord. We'll see what are the intrinsic causes that we have. In intrinsic causes, because of the deformity, the spinal cord is stretched over a prolonged period of time, leading to the paraplegia. And other causes are your tubercular meningomyelitis, where the meninges is getting irritated because of the tubercle bacilli and it is inflamed. It can be because of your thrombosis of the veins and the arteries getting inflamed because of the TB disease. It can be because of pathological dislocation and subluxations of the vertebral column. And here syringomyelic changes, that is accumulation of fluid around the spinal cord, leading to the paraplegia. These are some of the intrinsic causes. The rare causes of the Pott's paraplegia are the spinal tumor syndrome, which I'll talk about in the last. Next slide, please. Coming to the extrinsic causes can be because of active disease, which present earlier, that is your early onset. And there can be a heel disease. In active disease, it could be because of the caseous material and the fluid that is there, what is known as the cold abscess, or it could be because of the granulation sequestra of the bone that is compressing on the spinal cord, or it could be a pathological subluxation and dislocation that is happening in an active disease. In heel disease, because of the progressive bending, it can form an internal gibbous, which is compressing on your spinal cord. It can be because of fibrosis of the dura. It could be because of the sequestrum of the vertebral body that is there, or the canal getting narrower over time, that is your spinal canal stenosis, or the TB debris pressing on the spinal cord in a heel disease. These are some of the extrinsic causes where in heel disease you can have paraplegia. Next slide, please. We have a classification of how a patient can present to us, which is proposed by Kumar and Tulli. There are 4 stages. In stage 1, there are negligible symptoms and the patient is completely unaware that he has a tuberculosis of the spine. However, when a physician inspects him, there can be an extensor response of the plantar reflex, or he can have brisk tendon reflexes because of the spinal cord getting involved in earlier stages. In stage 2, we have mild symptoms where the patient has some deficit, but he can walk and mobilize with some amount of support. The patient experiences clumsiness, a loss of coordination, and he has signs of spastic paresis. In stage 3, what we call as paraplegia in extension, the progressive flexion or the forward bending has not yet happened, and the patient is non-ambulatory, but his sensory deficits are less than 50%. In severe form of disease, what we call as paraplegia and flexion, we have all the symptoms of stage 3, that is the moderate symptom. Along with that, patient has a complete paralysis with the body in flexion, and even your bowel and bladder, that is your sphincters, are getting involved, and the sensory deficits are more than 50%, which is the stage 4. Next slide, please. We know what are the clinical symptoms that can be there, why they are happening, what complications can happen post this spinal 2B. But one more complication that is there is the cold abscess. What happens in cold abscess? The TB bacilli is forming a granulation tissue, granuloma. The debris are there, the bony debris are there, your leukocytes are there, macrophages are there in chronic inflammation, and your fibrous tissue is surrounding the same. This leads to a formation of a cold abscess, where this abscess, which is liquefied, drains under your ligaments, or the anterior longitudinal ligament, or the paradiscal area, and the posterior longitudinal ligament, through which the abscess drains, and it can reach various sites on your body, even though the primary focus is somewhere else. On histopathology, this caseous material can contain the leukocytes, the bone debris, and the tubercle bacilli itself. Next slide. In the cervical region, even though the cervical spine is involved, it can track to your retropharyngeal areas and the neck, leading to difficulty in breathing, difficulty in speaking, and stridor. From the cervical region, they can track to your cervical triangles and the brachial plexus, leading to compressive symptoms. They can also reach to mediastinal areas and pleural irritation, leading to pleural effusion. This is in the cervical region. Coming to the thoracic region, next slide, please. In the thoracic region, they can form a paravertebral swelling, where the collection of the abscess is there beside your spinal column, and they can track down in your under the rib, along the intercostal vessels, to reach the anterior mediastinum, to form swellings in your anterior chest wall. This is your thoracic spine, draining to form cold abscesses even in the anterior region. Next slide, please. In the lumbar region, you can have the paravertebral swelling, and the lumbar abscess can drain into your along the psoas muscle to reach the inguinal ligament, and they can track down even as low as your ankle. This is the cervical abscess tracking down from the lumbar region. Next slide, please. Coming to the last entity, that is the spinal tumor syndrome, which is nothing but a healed TB presenting like a malignancy. Why this happens is because there are neurological deficits, but there is no radiological evidence of TB. This can be because of the tuberculoma of the spinal cord, or the extradural granuloma that is compressing on the spinal cord. In the image, we have the vertebral body and the disc that is destroyed, and the granulation tissue has migrated in order to compress the spinal cord, leading to paraplegia without active TB disease. This is your spinal tumor syndrome. Next slide, please. Next slide. Yeah, that is in brief about the pathology and the clinical features of spinal TB. Thank you.
Yes, thank you, Dr. Hegde. It's over to Dr. Jacob for the session, Diagnosis and Management of Tuberculosis of the Spine. It's over to Dr. Jacob.
Share my screen. Is it visible?
Yes, yes, Dr. Jacob.
Okay. All right. So I'll be talking about the diagnosis and management of tuberculosis of spine. So diagnosis is primarily based on three things. One is the clinical, one is neuroimaging, and the other is etiological confirmation. So clinical, Dr. Nirath has already just discussed. We'll be concentrating more on the neuroimaging part of it. And for, of course, etiological confirmation, Dr. Sandeep has already spoken to us about it. Acid fast bacilli will be visible on microscopy or on culture of the material of whatever lesion we are getting from the patient. So we'll just go over this. We'll be concentrating more over the neuroimaging part. Starting off with a plain X-ray. So any patient who comes with a TB spine, you will first ask for a X-ray. This is one of the most easily available investigations in resource poor countries. So TB is a disease of poor sanitation, poor hygiene under developing countries, and X-ray is the most valuable source of imaging that we can get more or less at all places. What does an X-ray show us in TB spine? So it will show us rarefication of the vertebral end plates. There will be loss of disc height. There will be destruction of the bone, as well as new bone formation in a healing case, and soft tissue abscess if they are significant enough to throw a shadow on the X-ray. Now, reading it in words is one thing, and seeing it on an X-ray is another thing. So, in the next slide, I'll show it to you in the form of an X-ray. So, the left side we have a normal spine, and the right side we have the AP and lateral images of a TB spine. So, starting off on the left side, you see where the red arrow is pointing. It is pointing to the inferior most part of that vertebra where there's a white line. That is the end plate, and that is the intensity of white a normal end plate should be having. Look on the right side where the red arrow is pointing. The end plate of those vertebrae are slightly more thinner. They are not as dark or as intense as the left side. So that is rarefication of the end plate which is happening there. Look at the green arrow on the left side. The space between both the vertebral bodies is significant on the left side compared to the right side. That space where the green arrow is pointing is quite significantly reduced. So there is loss of disc height. That space is where the intervertebral disc is sitting. Look at the blue arrow on the left side. That is what a normal vertebral body size should be looking. A nice proper rectangular box matching with the height of the one above, the one below. If you look on the right side, you see that that bone is broken, it is collapsed, it is crushed, and there's some white intensity in the middle, probably the infection which is there, which has led to angulation of the spine. You can see the spine is bending like an apex, with the apex pointing more towards the right side. So because that vertebra has collapsed, it is leading to a kyphotic deformity. If you look on the middle image where the yellow arrows are pointing, it's written the cold abscess. So you see that white hazy shadow around the vertebra. That is where the cold abscess has collected and is showing up on an X-ray. Now, this is classically called as a bird's nest abscess because that entire appearance looks like that of a bird's nest around the vertebra, like a bird is constructed its nest around the vertebra. So this is how the X-ray findings would be visible. So rarefication of the end plates, loss of disc height, collapse of the bone, there's destruction of the bone, as well as at some points new bone formation, as well as soft tissue shadows in the form of an abscess are visible on an X-ray. From an X-ray, we move on to a CT scan. We can order a CT scan. How is this going to help us? CT scan will show us the abnormalities which are visible on the X-ray, but in a much more detailed fashion. In an X-ray, is just AP and a lateral. It just shows us a 2D picture. But a CT scan will show us in much more details, in more planes, in sagittal and coronal, as well as a transverse plane. So it will be able to tell us the destruction which is occurring, whether that is a fragmentation type, whether that's an osteosclerosis type, whether it's an osteolysis type, whether it's a subperiosteal type. So it gives us much more finer details than what an X-ray would give us. Also, the paraspinal tissue abscess, which was a hazy structure in the X-ray, is now much more clearer on a CT scan. Also, in the transverse cut of a CT, we can see the spinal canal also. In the spinal canal, is there any inflammatory tissue which is gradually encroaching and compressing on anything? We can see much better in a CT scan as compared to an X-ray. Of course, a CT scan will also help us if we need to put in a needle and reach the site of where the abscess is or where the translation tissue is, and we need to take a biopsy. So a CT guided biopsy is going to give us that accuracy to be able to get that particular tissue for histopathological examination. After CT scan, the next step is this is how a CT scan would look like. So you can see here in a sagittal plane, you can see where the white arrow is pointing on the left side, the affected bone, and on the right side, you can see a transverse cut. You can see exactly which part of the vertebra is affected, whether it's the whole vertebra, whether the part of a vertebra, whether it's a fragmentation type, how much of it is affected can be clearly delineated in a CT scan. After a CT scan, MRI. Now, MRI is considered as the neuroimaging of choice because it shows everything, the soft tissues as well as the bony structures also. So it's more sensitive and more specific. So whatever an X-ray shows us, the vertebral bodies, the cold abscess, the vertebral collapse, MRI also will show. But in addition to that, it also shows us something which the other two don't show. That is the status of the spinal cord. So if the spinal cord has been compressed, to what extent it has been compressed, whether there's cavitation inside the spinal cord, whether there's edema inside the spinal cord, whether there's an intramedullary or an extramedullary tuberculoma, where the granulation tissue is spread, how far it has spread, where all has the cold abscess tracked down. Much more clearer soft tissue delineation is given to us by the MRI as compared to the bony structures. So an MRI is therefore considered as the neuroimaging of choice. It literally shows us everything. This is an image of how an MRI would look like. As you can see there, in the middle are D6 vertebra collapsed, and it is protruding backwards with the pus, which is impinging on that gray structure, which is the spinal cord. Probably the patient is having paraparesis or even paraplegia. Even the image on the right shows us where the red arrow is pointing that something is projecting out into the spinal canal. So this gives us a much more comprehensive picture as to what is going on there with the bony tissues as well as with the soft tissues. Beyond MRI scan, we also have a bone scan. Now, the bone scan is not very helpful. It is a more costlier investigations, and it doesn't help as much as even a CT would actually. A bone scan is only going to tell you whether there is an infection or not. So anything which is infective will show up as a hot spot in the bone scan. If that infection has led to avascular necrosis of any particular part of the bone, that bone will show up as a cold spot. So it could be osteomyelitis, it could be fungal infection, it could be brucellosis, it could be tuberculosis, it could be anything. It will still pop up as a hot spot only. It will not tell you what it is. And why do we need a bone scan? The only help or advantage what a bone scan is going to give us is it's going to tell us the difference whether this is an infective or whether it is a metastatic type of lesion. And how it tells us that is, metastasis usually involves most of the vertebrae and widespread all over the body, whereas TB spine will be more so just to the spine at different levels at that spot. So bone scan is not very helpful, but it is one of the investigations you can mention in your answers, but just to say to differentiate between a metastatic disease and a infection. Lastly, the cytology and microbiology, Dr. Sandeep has already told us. We'll quickly just rush through it. Acid-fast bacilli will be seen on the specimen. Tubercle will be seen in the specimen. Langerhans giant cells will be seen in the specimen. Culture of the bacteria also will help in identification of the causative factor. However, culture takes a really, really long time. You take the specimen and put it in an ALG medium, it will take 6 to 8 weeks for the growth to appear. Nowadays, we also have the PCR, polymerase chain reaction, which is very sensitive and again, very specific. So even 10 to 50 tubercle bacilli, it picks up in a shot, and we are able to get the diagnosis faster. So quantiferin gold assay tests for tuberculosis, these really help us in identifying the disease faster. So in summary, when a patient comes to a TB spine, X-ray should be done, CT or MRI should be performed in all these patients. The spinal MRI will tell us the nature of the bony destructions and how much of the spinal cord is involved. Screening of the whole spine should also be done to look for skip lesions. The patient may complain of pain in the mid-back. He may have a kyphotic deformity in the mid-back. He could have a secret lesion hiding somewhere in the sacrum or even the cervical spine. When you take an X-ray, you are limited to that one specific spot unless you take a whole spine X-ray. But a screening of the whole spine in an MRI will show you the entire spine and help you to find these skip lesions. As Dr. Sandeep said, non-contiguous lesions may be present there. Therefore, this screening helps you to pick up those. All patients should have a chest X-ray to make sure that the pulmonary tuberculosis part is addressed, and whatever material which is taken out from the patient through a biopsy or a surgery or in whatever way, we will be able to send it for microbiology, histology, and culture so that we get to know what exactly the pathology, the causative organism is, and to what extent it needs to be dealt with. Because we have simple TB, we have drug-resistant TB also. Right, now coming to the treatment part. Now in treatment, the fact that anti-tubercular medicines were discovered or invented in 1948 to 1951 was a very big achievement. It was a very important milestone. Based on this discovery as such, we can divide the treatment eras into a pre-anti-tubercular, post, and again a post. So the pre-anti-tubercular era was when patients were treated with ancient traditional beliefs. Now this varied over different countries with different people. People did whatever they felt was correct, and they got varying results also, most of which were failures. Post-anti-tubercular era was when people advocated surgeries. So they gave ATT, anti-tubercular medicines, as well as they advocated surgery radically. Again, they started going into failures. I will explain to you why. Then came the era, the present era, the post-anti-tubercular era, where a middle path regimen was considered. Middle path meaning where medicines were given and surgery was done only in certain indicated cases, not for everybody. Medicines were given that did majority of the job. Only those who were not responding were taken up for surgery. So the pre-anti-tubercular era. Now we're talking about 1800 and beyond that, the earlier part in BC era, where in ancient India, the Atharva, the Vedas also used to mention that tuberculosis was treated with sipudra, that is a herbal preparation, and sunshine. So basically, since tuberculosis is a disease which was found in poor hygiene, poor sanitation, they figured that bringing the patient out to a much more better place, environment, with just fresh air and sunshine would help them to get better. They probably saw few people getting slightly better based on this. Hippocrates and Galen, they tried to correct deformity corrections by simple manual pressure, traction, mechanical appliances, but of course they failed because they're not addressing the main issue. In fact, in that era, sanatorias were created, which were considered as health resorts. Patients were just kept to take rest and heliotherapy. Heliotherapy means getting sunlight. Exposed to sunlight, fresh air, rest, good food, immobilization. So what we guys consider as vacation nowadays is what they used to use as treatment in the pre-anti-tubercular era. And these patients were kept in these health resorts for 1 to 5 years. They had to be there for that long to get okay. And this is because tuberculosis used to pass through a certain set of stages which spanned over 3 to 5 years. So you take care of the patient in a good way in those 3 to 5 years, he will invariably become okay, provided he is not getting complicated. So TB used to go about a stage of onset, which starts from 1 month to 1 year, where the disease was localized, there was warm swelling, it was beginning to cause destruction, to just developing inside. Over the next 1 to 3 years, the slow progressing the disease started destroying the vertebra, started causing deformity, started having contractures, subluxations, and the kyphotic deformity started developing in these patients. After which, during the second to the third year of the onset of the disease, this abscesses started getting resolved. It started becoming latent. The sinus started healing. The destroyed bones started forming up again, started becoming mineralized. And whatever deformity was there, it got, you can say, malunited, but that's not the right word, into whatever position it was. So this diseased area generally healed with a kyphus or a scoliotic deformity at that point. So as it passed through these stages, the patient would either survive or not survive. Then came the pre-chemotherapy operative treatment era. So here they said that why not go ahead and operate these patients, take out that abscess immediately so that the load is decreased and the patient becomes much more better. But whenever they went in and removed the abscess, they were not killing the bacteria. They were not addressing the issue. They were not they were just removing the load. They were cutting open and entering inside and stitching back. This resulted in that abscess to drain through the surgical site. So it started resulting in persistent serious sinuses and ulcers. And then that also became an inlet for pyogenic infection to happen. So this started leading to death faster than a natural history course. So Callet, who was a surgeon during that era, used to say, a surgeon who, so far as tuberculosis is concerned, swears to remove the evil from the very root will only find one result awaiting him, that is death of his patient. So in other words, you go operate on any patient, that patient is going to die. Still, they went on and tried to invent new methods of treating these patients with surgery. But whenever they try to do a spinal fusion to correct the deformity, the pus and debris, the necrotic bone, which were there, they all just remain there. It would form back. And whenever there was instability, pain used to increase. These dormant lesions used to flare up again. And again, you used to have pus and sinuses coming up. So most of these surgeries were failing to address the main issue as well as any other neurological deficits. Then came the post-anti-tubercular era. So this was an era where they realized that surgery is not really going to help that much. We need to try more of the anti-tubercular medicines. So they brought about a middle path regimen in which medicines would be given and surgeries only if necessary. So the components of a middle path regimen was, number one, bed rest and immobilization. Basically make the patient take rest so that there's no deformity forming and no collapse of the bone. So patients are advised bed rest for a specific period to allow the spine to heal. Now, during the era when this was brought out, Tully advocated that the patients lie down on beds which were made up of plaster of Paris, not simple beds, but beds with plaster of Paris. The only reason why is to make sure that the patient and the attenders realize that this is a serious disease. Lying down on a bed and relaxing is not the way of treating this. They wanted them to make sure that lying on a plaster of Paris bed made sure that the patient realized that something serious is going on and they take it seriously. So patients are made to lie down on such a hard bed, followed by immobilization with the help of a plaster, a jacket, or a brace. This stabilizes the spine, prevents it from a further deformity forming. Regular monitoring was always done. We took X-rays, we took ESRs at every 3 to 6 months to make sure that the kyphosis is not increasing, disease is not spreading, or more abscesses are not forming. If at all there was an abscess found superficially somewhere, that needed to be aspirated. So superficial abscesses were aspirated and streptomycin was injected at that site of aspiration. If any sinus was found, usually with the tablets, that would heal within 6 to 12 weeks of treatment. In case it does not heal, then you need to go ahead and excise it. But you need to give it a good amount of time for the anti-tubercular medicines to work. Then the anti-tubercular medicines, this form the cornerstone of the middle path regimen. I will explain that a little bit more detail later on. Nutritional support, you know that a patient who's suffering from tuberculosis is going to become wasted, is going to lose a lot of weight. So a balanced diet, sufficient protein, vitamins, always recommended for his well-being. Surgery-wise, if you look, posterior spinal arthrodesis was indicated in those patients who had an unstable spine, which means the spine was destroyed to a level such that even simple movement, getting up movements, used to cause significant pain with the risk of damaging the spinal cord. It was ideal in such patients to fuse that spine so that there's no instability there. Once instability was addressed, the patient was encouraged to move around as early as possible. So as soon as pain was reduced, patient was made to walk with the help of braces. And once pain was reduced, also back extension exercises from 3 to 9 weeks of starting treatment was advocated. Use the brace for 1.5 to 2 years so that no deformity forms further up. Any disease wherein the abscess was formed despite 3 to 4 weeks of taking medicines, then it was ideal to excise that abscess out, because that abscess can travel along the meninges and cause meningitis. Such cases, it was advised to get a surgery done. If not, unless unstable, not required. So surgical intervention, like I said, considered in cases where there is significant spinal instability only. Neurological deficits, if present, minor, it is okay. No need to neurological deficit, then it's operated. Or if the conservative management, that is the tablets, are not working, then you need to operate such patients. So this was the middle path regimen. Now coming to the anti-tubercular medicines, WHO gives us this table where spinal TB will fall under category 1. In category 1, they say 2 months of HRZD followed by 4 months of HR or 6 months of HE. Now H is isoniazid, R is rifampicin, Z is pyrazinamide, E is ethambutol. I hope you know all that. So 2 plus 4, that is 6 months, or 2 plus 6, that is 8 months. So WHO advocates around 6 months of therapy for musculoskeletal tuberculosis. There were other regimens based on how much of the disease is there, how compliant patient, what type of disease it is, whether it's resistant or not. So based on that, somebody's mic is on. Right. So based on the different types of regimens, there were the advocation of these anti-tubercular medicines for a period of 6 months or 9 months or 12 months or even up to 18 months was advocated. But 18 months is a really long time for a patient to keep taking tablets. Therefore, the American Thoracic Society, they brought out a guideline saying 6 to 9 months regimens is enough as long as it contains rifampicin for the treatment of bone and joint and spinal tuberculosis. This is equivalent to taking 18 months of the medicine without rifampicin. Now, some experts consider that 6 months may be too less. They advocate 9 months. Some of them say that if there has been an instrumentation, if there's been a surgery, if there are rods and screws in the patient, then it's ideal to extend it further to another 12 months. So 6 months, 9 months, 12 months, category 1 of WHO is ideal. Now, indications for surgery is, like I said before, if the tuberculosis therapy is failing, you need to operate and remove the focus. If the deficit is progressive, the key word here is progressive. Just presence of a neurological deficit is not an indication. If that deficit is increasing over time despite your treatment, then you need to operate and salvage that spinal cord. If there is severe weakness, a minor deficit, nothing needs to be done. Severe weakness, where grade 1, grade 2, probably then you need to operate. If there's instability of the spine, which can lead to a progression of the deformity, you need to operate. Severe pain and deformity is again an indication for this. So when we do a surgery, we are not only correcting the deformity, we are not only addressing the paraplegia, we are also getting tissue which can help us for the diagnosis. It is removing the infected focus, which reduces the burden, the load on the patient. It reduces the need for tablets for a longer course. So a patient who actually required 18 months, if you do a surgery and with an indication, you can reduce it to probably 9 months or 12 months. Earlier recovery, reduced recurrence is another advantage. So basis of the surgery is we are planning to do is we try to get adequate debridement. We try to decompress it much. We need to maintain the spine stable and correct whatever deformity is present. So among the surgeries, the most commonly ones used are the anterolateral and the posterior one. So I'm just showing you the approaches as to how the spine is approached from. The anterolateral, patient is made supine, and then the ribs are moved and the diaphragm is removed, and then we reach the anterior portion of the spine. Now this is more preferred, the anterolateral part. However, it has a steep learning curve because you're coming very close to the lungs. You should not be damaging that, as opposed to the posterior approach to the spine, where directly go posterior. So when there's an anterior collection, it's always better to go to an anterior lateral approach. There is an operation called as a Hong Kong operation, wherein it was the first time where an anterior approach was done and anterior fusion of the bones was done, and that became a milestone because it became one of the most successful surgeries for TB spine, the Hong Kong operation. So these are two approaches that we use. I'll just show you an image as to how it is addressed. So on the top left, you can see that there are two vertebrae which are involved, the paradiscal type. On the right, the B side diagram, that is a cage, a metallic cage, which is being filled with bone graft. C is the approach that we go to, and D is where you can see the instrumentation put. So this would be the X-ray as to how that would look like. We have the screws and the rods holding the spine, so deformity is corrected, this instability is addressed, and the cage, that metallic mesh cage with the bone graft inside there, that is going to be helping for the fusion of those vertebrae, so that there is no instability there. One thing I missed out to say is that Hong Kong operation, that doesn't use a cage, it uses a cut part of a the rib to act as a cortical strut graft to achieve fusion. So there was a study done where they wanted to see whether just medicines were okay or medicines with surgery would be better. So the study assessed people who took only medicines and those who received surgical treatment. This surgical treatment was indicated for when the kyphosis angle was increasing or the neurological deficit was present. Again, not increasing, neurological deficit present, bone was fusing, or they also assessed the recovery from the disease and the recovery rates. These were evaluated and they found out that there was no difference between those who were taking only medicines and those who took medicines along with surgery. So which means to say the mainstay of treatment in middle path is the medicines need to be going. Surgery in the presence of a progressive neurological deficit, instability, progressive kyphosis more than 50 degrees, or failure of conservative management with the medicines, then surgery is indicated. Most of the time, just chemotherapy would be enough. Emergency decompression, only one indication when there's an acute spinal cord compression because of TB spine. So sudden kyphotic deformity and it's pressing on the cord, paraplegia, immediately operate, decompress the spine, good results. Just a note on different types of resistance in tuberculosis. So we've heard of MDR-TB, multi-drug resistance, that is bacteria which are resistant to at least isoniazid and rifampicin. Pre-extensively drug resistant TB is same MDR-TB, that is isoniazid and rifampicin, along with a fluoroquinolone or a second line injectable, that is amikacin, captivomycin, or kanamycin. So MDR-TB plus resistance to either fluoroquinolone or a second line injectable. Extensively drug-resistant tuberculosis is the same thing, MDR-TB plus a fluoroquinolone and an injectable. So pre-extensive was fluoroquinolone or injectable. Extensively drug-resistant is and injectable. Here is another note on just the spinal braces so that you can see how the braces look like. These are the braces which are usually used in patients who have spinal TB and to prevent the deformity. A Jewett brace, there's an anterior strut as well as a lower belt. A Taylor brace, which straps around the shoulder with the front part of the brace, the back part of the brace having metal rods which hold the spine in extension. And you have the ASH brace. ASH stands for anterior spinal hyperextension brace, which prevents forward bending of the patient and maintains the patient's hyperextension. So this keeps the spine in its position and is very useful in maintenance phase for these patients. Thank you.
Thank you, Dr. Jacob. It was like I'm getting a comments online that entire panelists have like showcased the real worth of this education, medical education, which I was earlier talking with Dr. Hegde also. And everybody is saying that it's a wonderful session, mind-blowing session it was across. Now, I would request the main author of the book, Textbook of Orthopedics, Dr. Edward Nazareth, to kindly start with the question answer session based on the lecture.
Madam, can
Dr.
you start my video because I am not able to. Video is blocked as well as I can't share the screen also.
Okay, sir. Just give me 2 minutes, sir.
I
Give
am
me
disabled there. Yeah.
Sir, I have started.
Yeah. Can you start from slideshow?
Okay, sir.
At the outset, I thank CBS for giving us this platform. And I'll be having, Madam, next slide slow.
Yeah, I'll.
The main MCQs will be from this textbook. There is a nice chapter we have written about tuberculosis of the spine as per the CBME curriculum, and what is required for the undergraduate students, and MCQs also are from this book. So we'll go to the next slide. The first question is, the tuberculosis of spine is known as, you have 4 options there: Perthes disease, Potts disease, Schurman's disease, Friedberg's disease. Answer please. Potts. Yes. Madam, next slide. Yeah, it is Potts disease. Yes, many have answered. Correct. Next, madam. Tuberculosis of spine is most common in this region: cervical, lumbar, thoracic, lumbosacral. Your answer is? Madam, next slide. Yes, it is thoracic. It is thoracic spine, which is this one. Yeah. We'll go to the next question. Thoracic is because, madam, next slide. Because thoracic spine is involved in about 65% of the cases. Lower thoracic vertebra are the most commonly involved, about 50%, followed by the lumbar spine. Next. Tuberculosis is a hematogenous infection, primary being the lungs or the abdomen viscera. This has to be remembered. From there, you get the where the patients get the tubercular infection of the vertebra. Next. The predilection of the spine is, it is already explained, because they are highly vascular. Even in adults, spine are highly vascular. That is the reason why the bacteria hematogenous, they spread and they come and land into the vertebra compared to the other bones in the body. Other bones, mainly joints are involved, but compared to the bones, the spine, vertebra are commonly involved because they are highly vascular. We'll go to the next slide. The common site of tuberculosis in the vertebra is central, anterior, paradiscal, appendicular. Yes, very good. Yes, it is. So these are the various, right? Whereas the paradiscal is the commonest one. Madam, next. Is because it is already explained by Neerath as well as by Sandeep, because simultaneous involvement of the either side of the vertebra, because it is supplied by the common artery. The bacteria come through the artery. We'll go to the next one. The tubercular organism through Batson's paravertebral venous plexus are mainly responsible for paradiscal, central, anterior, or appendicular. Yes. Yeah. Madam, we'll go to the next slide. It is central lesion. Batson's venous plexus in the vertebra. They have a valvular system that allows the free flow of blood in both the directions depending on the pressure in the intra-abdominal or intrathoracic cavities. During sternous activities like coughing, sneezing, the infection spread intraosseous, and central type of lesions are common when the organisms come through Batson's paravertebral venous plexus. Next question. The earliest symptom of tuberculosis spine is spasticity, pain on movement, paraplegia, night cries. Answers, please. We'll go to the next slide. It is pain on movement. That is the commonest sign. Madam, next slide. Next slide. Because symptoms of tuberous spine are insidious in onset, the usual clinical symptom active stage of the disease is stiff back, which is painful on movement. Next slide. The most common causes of early onset of paraplegia of tuberculosis spine are arterial thrombosis, sudden collapse of the vertebra, granulation pressing on the cord, or the cold abscess. Yes. Yes, we'll go to the next slide. It is the cold abscess pressing on the cord. Although all this can cause, because paraplegia active stage of disease is caused by the mechanical compression, instability, and inflammatory changes. Next. The mechanical compression is by abscess, granulation tissue, tubercular debris, caseous tissue, or localized pressure on the internals. So this is mainly because of the cold abscess. Next. So is the commonest site because it is a narrow spinal canal. The abscess from the forms and it remains in the localized under the anterior longitudinal ligament and enters the spinal canal through the intervertebral foramina to cause the cord compression. So you should know how it causes, and cold abscess is the commonest cause that causes early onset paraplegia. Next. The tuberculosis of the dorsolumbar spine, the cold abscess may not be present. It may not be present in the lumbar triangle, in the iliac fossa, in the suprapatellar pouch, in the upper part of the thigh below the inguinal ligament. Where it is not present, it is in the suprapatellar pouch. Suprapatellar pouch comes in the knee. So it is not connected to the spine in any way. So the correct answer is C, that is in the suprapatellar pouch. Cold abscess may not be seen in a thoracolumbar. The rest, all the three places, cold abscess may be seen. Eighth question, the tubercular psoas abscess, cold abscess, may not be due to the tuberculosis of lower thoracic or upper lumbar vertebra, 10 thoracic and below, lower cervical and upper thoracic vertebra, sacrum and sacroiliac joint, pelvic bones and hip joint. So which of the four, they do not cause psoas abscess? All are telling pelvic bones, hip joint. We'll go to the next slide. It is the lower cervical and upper thoracic vertebra because it is above the. So that usually it tracks down this one. It doesn't come to the psoas region. Lower cervical and upper thoracic vertebrae. Most of the time it confines to the thoracic region. Either is a bird nest abscess. So that is the answer. Next. Night cries in tuberculosis spine is due to. So there are four answers, like because of the nightmares, relaxation of protective spasm, reactivation of infection, or uncontrolled movements during sleep. Yeah, many are giving a correct answer. Next slide. It is relaxation of protective spasm that causes the cold night cries. Next question. This is already answered. Madam, we'll go to the next slide. First clinical feature of cord compression in tuberculosis is sensory changes, lower limb weakness, decreased tendon reflex, spasticity. We'll go to the next slide. It is spasticity because that is the one with the surgeon, this one. The earliest radiological sign of tuberculosis of spine is a concentric collapse of almost resembling vertebra plana, narrowing of the disc space, kyphotic deformity, bird nest abscess. Correct answer. We'll go to the next slide. It is narrowing of the disc space because it's the paradiscal lesion. So commonest sign is the narrowing of the disc space. Next. Yeah. A man is 56 years. We'll go to the known alcoholic presented with a severe backache following a fall. The radiograph of the spine revealed collapse of the vertebra with loss of disc space. Most probable diagnosis is because we are dealing with the topic. It is this, so this can be asked, and you tend to write because a person has fallen from the height. But remember that, sir, madam, next slide. Because loss of displace is characteristic for spine, fall may be an incidental finding. Many times patients come with this history, but when you take the X-ray, you see that this space is gone, and that is the correct answer is spot disease of the spine. Next slide. The ideal treatment of tuberculosis spine without neurological deficit is anterior decompression, posterior fusion followed by chemotherapy, anti-tubercular medicine alone, posterior fusion and chemotherapy, anterolateral decompression, bone grafting, fusion and chemotherapy. So answer is yes. Next slide. It is anti-tubercular. Dr. Jacob has already mentioned about that anti-tubercular medicine is the mainstay of the treatment of tuberculosis of the spine. Next. The most common sequelae of tuberculosis of the spine is fibrous ankylosis, bony ankylosis, pathological dislocation, chronic spondylitis. Next slide. It is bony ankylosis. See, compared to the next slide. See, paradiscal lesions are common in tuberculosis spine where the entire interdisc loss is lost and the disc gets sequestrated. As a result, during healing, adjacent vertebrae fuse each other, resulting in bony ankylosis. Next. So I think with that we are concluding. So thank you very much for your participation. I think this much of MCQs are enough. I thank CBS for giving us an opportunity to speak to our students. Madam, thank you very much.
Thank you, sir. Thank you, sir. I think you almost have replied all the questions. There is one question from Ashir Rao. How does pregnancy affect TB infection? And what considerations are important for pregnant individuals?
That is basically, that is a OBG question, madam. It doesn't come under orthopedics.
Under orthopedics, okay. What may be the main reason behind not achieving TB eradication, sir?
That is again P&SM question, and because of Jacob has already said, it is because the poor hygiene, our education is not proper. People do not continue the medicine for a long time. So that is one of the reasons which we are getting tuberculosis still is very active.
The investigation of choice for TB spine, I think this has been
already dealt by Dr. Jacob. He has already told.
I think most of the questions have been covered in all the presentations and in your question answer session also, sir. Sir, would you like to say something to the participants who have joined us today for this, or any of the panelists would like to speak anything, any words from their expertise and all?
I request all the students to read our book, textbook of orthopedics, because we have taken a lot of pain to write this book according to CBME curriculum, myself and Dr. Jacob. And it is whoever has bought the book and read, they are very appreciative about the contents, as well as it is very helpful to the exams also. So I request I suggest the students to buy the book, read the book, and suggest to their juniors also, because this is one of the best books that is available. That is the feedback which we have got. Madam also will agree with us.
Yes, I definitely agree. I really agree. Not being a expert from a medicine, but I have been in this field from last 20 years. And once I saw your book, I could see whatever I can observe, I can share over here is that the best thing I could find out is one, the language part was very, very basic so that students can understand. Even I as a non-medical student can understand that. Number two was that you have correlated the images, like the fractures have been correlated with the x-rays and then with the illustration. That is the best part. Like if you are showing a crack inside the bone, that has been shown with the illustration and the x-ray. That is how Dr. Edward and Dr. Jacob has tried to correlate the things. And this is the best part what I liked about the book, sir. And that is what request all the participants over here to kindly go through this book, give your comments, suggest us how we can make it the best CBME book, because this is how technical literatures are updated. One is the scientific approach, which the experts will give us. Another is the reader, because reader, the end customer, is our medical aspirants. They have to let us know how we can improve upon the existing content. Thank you very much. Thank you everyone over here. Thank you, Dr. Sandeep. Thank you, Dr. Jacob. I am in the I'm going to close this session with a hope that we will be making CBS Author Talks one of the choicest things which the students would look for further in the future. So I request everyone over here to let us know how you want us to improve the CBS Author Talks. And I am thankful to all of you that from your very busy schedules, you have come over here, shared your thoughts, given the presentations, tried to give best of your subject as a subject experts. And CBS will always be there to help you and support you for all these activities you want to do with us. You want to collaborate with us. Every student over here, every expert over here is welcome, and stay tuned with us on all our social media handles for the updates like CBS Author Talks or any student activity, and how they want to contribute in the medical education. They can always be there with us. And again, thankful to all the panelists, the amazing panelists, Dr. Edward Nazareth, Dr. Jacob, Dr. Neeraj, Dr. Sandeep. Thank you very much. It has been a wonderful session. I would also like to thank all the CBS ambassadors who have promoted this program. I would like to thank all my sales and marketing team across India who has helped me to support this session, penetrate among the students. But I am expecting more and more participants in every future CBS Author Talks. All the doctors, all the participants over here need to do a bit of mouth service so that this platform becomes a future for every aspirant who comes to CBS. Thank you very much again. And I'm thankful to all my co-colleagues, Ms. Simran, Ms. Daljit, and Neetu for helping me out to making this wonderful session possible. Thank you very much. Namaskar and good night to everyone. Thank you.
Thank you, madam. Thank you.
Thank you.
Thank you.
It was a great session. Thank you very much.